Hi everyone, I am Dr. Surbhi, periodontist and the voice behind the animated videos on Gummodont. Before we begin with the 2017 classification, you might be thinking why there is no animated video today, and it's because the 2017 classification is not something that I can make you understand through animation. It is something you understand clinically. And because it is so vast and so closely connected to real patient situations, a face-to-face explanation with the real examples make it much easier to understand. So in this series, we are not just going to go through definitions, we are going to think like a clinician and try to connect 2017 classification with clinical based decision making. And by end of this, you won't have to memorize this classification, you'll actually understand it. So how did this classification actually come into existence? This was not just one paper or one author's idea. It was the result of a global effort, and researchers and periodontists from around the world came together during the 2017 World Workshop on the classification of periodontal and peri-implant diseases and conditions. And their goal was very clear: to resolve the limitation of older classifications and create something more clinically relevant. By the end of this workshop, they presented around 19 review papers and 4 consensus reports. Now, one important point: although this classification was developed in 2017, it was published later, first by American Academy of Periodontology in 2018 and then by European Federation of Periodontology in 2019. So when we say 2017 classification, we are referring to the workshop where it was developed. Now the question is, where do you even start studying this? Because the classification is vast. I personally spent months going through all the papers during my post-graduation, and honestly it felt overwhelming. So the simplest way which I found out is there is one introduction paper by the American Academy of Periodontology. I like to call it the gold article of classification because it also links all the other papers together. It gives you a complete overview of the classification. And if you want to understand it more clinically, the European Federation of Periodontology reports break everything down in a much more practical way. So in this series, I have simplified everything into 3 parts. In this first part, we'll understand periodontal health and gingival diseases. In the second part, we'll understand periodontitis. And in the final part, we'll cover other conditions affecting periodontium and peri-implant diseases. But before we understand the new classification, we need to understand what we were using earlier, because only then you'll understand why this change was needed. So let's look at the 1999 classification by Armitage. Armitage classified periodontal diseases into multiple categories. These were gingival diseases, chronic, aggressive periodontitis, periodontitis as manifestation of systemic diseases, necrotizing periodontal diseases, abscesses, endoperio lesions, and development or acquired deformities and conditions. Now, if we start with gingival diseases, they are divided into 2 main categories: plaque-induced and non-plaque-induced gingival lesions. Under plaque-induced, we have gingivitis caused by plaque alone, and gingivitis modified by hormonal changes, systemic conditions, and medications. So the disease remains the same, but its expression varies depending on the modifying or risk factor. Now, under non-plaque induced lesions, there is a wide range of conditions: bacterial, viral, fungal infections, genetic disorders, systemic diseases, allergic reactions, and trauma. So even at the gingival level, the classification becomes quite extensive and complex. Now, if we look into periodontitis, he separated chronic and aggressive periodontitis and subclassified them on the basis of extent and severity. Extent was defined by number of sites. If they were less than 30%, it was localized periodontitis, and if they were more than 30%, it was generalized periodontitis. And severity was characterized on the basis of amount of clinical attachment loss. Slight attachment loss was 1 or 2 mm of cal, moderate was 3 to 4 mm, and severe was more than 5 mm clinical attachment loss. So this system attempts to include almost all periodontal conditions within defined categories. However, when you apply this in clinical practice, some important limitations become very clear. First, the distinction between chronic and aggressive periodontitis is not always evident in real patients. Second, the gingival classification becomes quite elaborate and complicated, with multiple overlapping categories. And most importantly, there is no clear definition of a periodontal health. which is actually the starting point of diagnosis. And lastly, none of the previous classifications included peri-implant diseases and conditions. So although this classification is comprehensive, it does not fully guide clinical decision making. And that is exactly why a newer classification was needed. One that doesn't just list diseases but help you actually diagnose a patient. Now let's focus on the 2017 classification. Here, they first divided everything into two broad groups, periodontal diseases and peri-implant diseases. And within periodontal diseases, they introduced three major categories. First, periodontal health and gingival diseases. Second, periodontitis. And third, other conditions affecting the periodontium. And today we will focus on this first part, periodontal health and gingival diseases. Because unless you understand what is health, you cannot define a disease. So, if we focus on the first category of the 2017 classification, they have broadly divided it into three parts: gingival health, gingival diseases due to dental biofilm, and gingival diseases not induced by dental biofilm. At first glance, this looks very simple, right? But the real understanding comes when you understand what health actually means. So if you look at the European Federation of Periodontology Report 1, they defined periodontal health into two types: pristine health and clinical health. Now, pristine health is easy to understand. Pristine literally means original, untouched or perfect. You can remember it like P for pristine and P for perfect. So there is no inflammation, no bleeding and no attachment loss. Basically ideal conditions. But in real clinical practice, this is very rare. That is why the concept of clinical health becomes important. Now, clinical health is more practical and more relevant to what we see in patients in daily basis. A patient can still be considered clinically healthy even if everything is not perfectly intact. According to the definition, in a non-periodontitis patient, clinical gingival health is defined as less than 10% sites showing bleeding on probing and probing depth of 3 mm or less. Now, this can exist in two situations. One, intact periodontium where there is no attachment loss, and second, reduced periodontium where there is attachment loss. And this is where things become very interesting. Now, if the patient has a reduced periodontium, that means there is some amount of clinical attachment loss. There are two possibilities. Either the patient never had periodontitis, or the patient had periodontitis in the past but is now successfully treated and stable. Now, in a treated periodontitis patient, clinical health can still be present even if probing depths are slightly deeper. So, we accept up to 4 mm of probing depth. But there should be no bleeding on probing at these sites because bleeding at 4 mm indicates possible disease recurrence. So here the health does not mean perfect tissue, it means a stable condition. Now let me give you one simple clinical example. A patient comes with gingival recession. There is a history of periodontal disease, but currently there is no bleeding, no inflammation or no sign of active disease. Now how would you classify this? Earlier, we would label this as chronic generalized periodontitis with generalized gingival recession, irrespective of whether the disease was active or not. But now we understand that this patient is actually healthy but with a reduced periodontium. And this is one of the biggest conceptual shifts introduced in the 2017 classification. Another important point, the definition of health may vary slightly between research and clinical practice. In research, stricter criteria are used to identify all the cases. But in clinical practice, we avoid overtreatment. So a 4 mm non-bleeding pocket can still be considered stable in a treated patient. And before we move ahead, just remember this one thing. Health is not always perfect. Health can also be stable. And now when we know what health is, the next step is to understand what happens when inflammation begins. So the first category here is gingival diseases due to dental biofilm. This is what we commonly call plaque-induced gingivitis. Now the concept here is simple. The primary cause is plaque or dental biofilm. And the most important clinical sign is bleeding on probing. And the moment bleeding crosses 10% of sites, we no longer call it health, we call it gingivitis. Now within this, there are three important subgroups. First, gingivitis caused by biofilm alone. Second, gingivitis that is modified by systemic or local factors. And third is drug-induced gingival enlargement. Now, instead of memorizing these, let's understand this logically. The disease is still caused by plaque, but its severity or presentation is influenced by certain risk factors or modifying factors. Some factors increases plaque accumulation like plaque retentive restorations and oral dryness. And some factors modify the body's response like smoking, diabetes, hormonal changes and certain medications. So again, plaque is the primary cause, but these factors modify the severity. For example, a patient with poor oral hygiene will develop gingivitis. But if the same patient is pregnant, the inflammation may be exaggerated. Similarly, in diabetes or due to certain medication, the gingival response becomes more severe. So always remember, no plaque, no gingivitis. This is the foundation of biofilm-induced disease. Now the third category is gingival diseases not induced by dental biofilm. Here the cause is not plaque. These include conditions like genetic disorders, specific infections, immune-mediated diseases, reactive lesions, neoplasms, systemic conditions, and trauma. So the approach here is completely different. If you see gingival changes, but oral hygiene is good and the presentation is unusual, you should think beyond plaque because not all gingival diseases are plaque-induced. Now there is one concept in this classification which is slightly challenging but extremely important to understand, and that is gingival inflammation on a reduced periodontium. Now the problem here is periodontitis causes irreversible damage. So once a patient develops periodontitis, they always remain at a higher risk of recurrence. And that is why we call once a periodontitis patient, always a periodontitis patient. Even if patient is currently healthy after treatment or has shallow pockets or even has 4 mm pockets without bleeding, they are still considered a periodontitis patient because the history of disease, it never disappears. So based on current status, a treated periodontitis patient can be in 3 stages. Controlled, which is stable and healthy. Remission, there is some amount of gingival inflammation present. And uncontrolled, where disease recurrence has happened. Hence, instead of re-diagnosing the disease again and again, we describe the current condition of the same disease. Now this brings us to the very important distinction, gingivitis versus gingival inflammation. In a patient who has never had periodontitis, we use the term gingivitis. But in a patient who already has a history of periodontitis, we do not call it gingivitis. Instead, we use the term gingival inflammation. Even though both means inflammation, we avoid calling it gingivitis because a patient cannot be categorized a case of periodontitis and a case of gingivitis at the same time. Now, this distinction is not just terminology. It directly affects the treatment. So if a periodontitis patient shows bleeding at shallow sites, it does not always mean disease recurrence. Sometimes it just needs oral hygiene reinforcement and plaque control and not aggressive periodontal therapy. So to summarize this section, we have gingival health, biofilm-induced gingivitis, and non-biofilm-induced gingival diseases. And the key to understand all of this is very simple. First, identify health, then check for inflammation, and then determine the cause. So, this concludes the first part of 2017 classification. In the next part, we will focus on the types of periodontitis along with its staging and grading, and periodontitis as a manifestation of systemic diseases. Thanks for watching. Follow and subscribe to Gamodont for more simplified periodontics.